In the trenches, my latest interesting patient. So, what to do? Stop the clot. So, this is 53-year-old woman, past medical history of type 2 diabetes, hypertension, lipids, and chronic kidney disease, baseline creatinine around 1.5. She just vacationed in Florida and was on a bunch of air flights, long air flights. Comes home with a swollen left lower extremity. Sits on it for close to a week, doesn't contact the doctor's office. Then she finally contacts the office and winds up coming in a couple days later. The doctor who was seeing her then basically ordered a venous ultrasound duplex, and it showed acute DVT in the left femoral vein going to the popliteal vein. This is not a surprise. It is not a surprise. At risk, multiple flights, swollen leg. And that was it. Started on the Pixaban, 10 milligrams BID for a week, finishing that up and transitioning to 5 milligrams BID. I evaluated her, not that much leg edema, but I asked her one question: are you short of breath? And she was very short of breath. And she had the shortness of breath last week, and she was short of breath on minimal exertion. She couldn't breathe, and this was new. No history of heart failure, no history of COPD, a non-smoker. So this kind of paralleled the leg swelling. So what do you do here? She's already anticoagulated. You know, does she go to the ER and wait a long time for evaluation? Now, her pulse ox was 95%, and her documented heart rate was 80 and respirations 20. I needed to be a little more thorough with that. What I did, I ordered a CTA, and this was difficult because radiology was very busy. And I had to do a lot of cajoling to get her in there, but they did it. And lo and behold, she had a large right-sided PE, main pulmonary artery, right pulmonary artery. And it was a distal main pulmonary artery, and it went into subsegmental vessels. They did not report any RV strain, and they did not report a large RV-LV ratio. The ratio was about 0.8, so it may have been a little bit larger than expected, but it was not 0.9. So what do you do here? What do you do? I ordered this test, and the issue is, did she need it? She's being anticoagulated anyway. We could assume this is a pulmonary embolism. And in my opinion, this needed to be done because PEs as a whole are more serious than DVTs, and she was very symptomatic. And, you know, the issue is she obviously didn't have a massive PE. Could she have had a submassive PE? And then if she has submassive PE, what would we do about it? How would that change anything? And she was very dyspneic. So what I did, I ordered a few things. I ordered an echo, and I ordered a troponin and a B-type MP. The echo, I'm really interested in the RV, and I'm specifically interested in something called mechanosine, which is a hinge point between the RV free wall and the RV apex. And with PE, okay, your RV apex moves normal, but your RV free wall is hypokinetic. And with large PEs that are significant, you could leak troponin and really have the equivalent of an RV infarct. And for intermediate or submassive PEs, you have high risk and low risk. High risk, you have an abnormal imaging and an abnormal biomarker. Lower risk, you have one or the other. Now, with high risk, intermediate high risk PEs, debatable what to do, and sometimes they do flow retriever and they do interventional work or catheter delivered lysis. Now, she's going to be a week or two out. I'm not sure if this is an option, but if she gets sick, we still need to think about it. The other thing, this is going to need to be followed because with large PEs, she could get the post-PE syndrome and possibly chronic thromboembolic pulmonary hypertension. So symptoms that need to be watched, especially if she's right ventricular dysfunction. And the other thing is she probably needs to be anticoagulated longer than 3 months. I would anticoagulate her for at least 6 months given this large PE, even though this is probably a reversible cause, and not 3 months, and maybe even longer, that with possibly reduced dose. So I think the CAT scan was the way to go, and she presented with both DVT and PE. And if you suspect both of them, you need to go after her. You need to go after both of them, especially the PE. That's my opinion. Right now, she's stable. We're in the midst of restratifying her. I'm going to continue her on apixaban. So that's what I did for this venous thromboembolism case. We're done.